Hey guys, you're watching the Best Practice Show where we take a look at the best business practices from the best dental practices all over the world. And if you're getting better in restorative dentistry, you know this is an important piece of the process is how do we visualize the treatment plan from wax up to definitive restorations. And I have got the master on today, Dr. Drew Cobb from the Dawson Academy. Do not miss this. Do me a favor, grab a pen and hit the share button. We'll see you in a few seconds. Hey guys, welcome back to the Best Practice Show. Thank you so much for watching. We love having you tune in. Love all of your suggestions for shows and keep sharing. We are just crazy grateful. Now up to over 30,000 followers, well in the hundreds of thousands on iTunes. So just love the suggestions, and we're going to work hard to bring you the masters to give you great answers or great solutions to some of your problems. And today is no exception. You're going to love this. So, hey, before we get started, couple show notes. We are shooting this live on Facebook. So as you have questions, as I'm talking to Dr. Cobb, ask questions. You can add them to the feed and I'll get the answer directly from him while he's on the show. And then continue to add questions later on because we always love to see what you're thinking and see if we can't give you an answer because we want you to get the most out of us. Now, my guest today, Drew, we've had you on many times before, but as I, have been out there, had a chance to speak to a lot of dental students, there are a lot of younger kids that are watching this now that may not know who Dr. Drew Cobb is, and you're a big part of what we call the Dawson Academy, which we're going to talk a lot about today. Can you tell us a little bit about who you are and what the Dawson Academy is before we get started, and just so people have a little context in who you are?
Sure, Kirk. Oh, thanks for having me back. This has been a blast doing these previous sessions together. So I'm Drew Cobb. I'm with the Dawson Academy. I'm the director of the core curriculum, and basically kind of sharing the core concepts that Pete Dawson instituted, decades ago that worked for him. And certainly they've kind of stood the test of time, and we've added different layers as dentistry has changed. But that core process of how we evaluate and deal with some of our patients that maybe have different needs than that kind of tooth by tooth patient that you're kind of taught in dental school. So it's kind of a format and a protocol to really how to deal with all your patients, but specifically how to follow a process to identify ideal treatment, long-term predictable dentistry for these patients. It's a process that changed my life. I went through this a couple decades ago. Although that's a bad way to say it, because I sound a lot older, but literally it changed my life as a dentist. I have so much fun practicing dentistry. It's just, I couldn't imagine practicing another way. So we're here to try to share some of those concepts with your people that are going to be on today.
Absolutely. And we're just so crazy grateful. Dentistry, again, ranked one of the top professions in all of the United States to be a part of. And you said the magic word predictability, which is one of the things that most dentists are on the eternal search for. And you guys have vetted this. I mean, you're talking about collectively hundreds, if not thousands of years of expertise behind the thought process. And Pete is just a genius. And I'm going to be down there at Seminar 1 with you guys this week. I could not be more excited. So a lot of fun.
Yeah, looking forward to it. It'll be fun.
Yeah. Now let's get into the why, because you and we're going to talk about these steps, and these steps you've refined. And as you watch this, you're going to see Drew's a master. But tell us the why behind the whole process and why this is so critically important, because it's one important piece, but this predictability piece between wax up and definitive restoration, there's some key steps here.
Absolutely. So, treatment planning always ends up a big part of this. That's kind of where we live and breathe daily. I mean, we got to come up with treatment plans because that's how we fill our schedule. Mm-hmm. So how do we do that in a predictable way, especially with these patients that have more advanced needs? We kind of refer to them as those specialty patients if you listen to some of the earlier segments that we did. But there's a process to go through that makes everything a lot easier. Mm-hmm. It's repeatable. It's the same process every patient, every time. Regardless kind of the complexity of some of the patients, it'll work for almost all the patients that have come your way. Implementation, anything new can be difficult.
Right.
So we like this stepwise process to kind of get you from the beginning to doing the dentistry. And in the end of the day, what we want you to be able to do, what we want to be able to do, is to do that dentistry predictably, low stress, and in an enjoyable way.
Yeah. And when you put all these pieces together, you're going to see out, on the other end of the process, you can enjoy it. Your stress goes down, because the potential for stress as somebody gets better in restorative dentistry is much higher. People think this is easy. You get to be a better dentist. It's easier. No, it's actually harder, because you've got to mitigate all the challenges that are ahead of you. I mean, the preciseness, the expectations, there's a lot here than just getting better, right?
Absolutely. And, there's a high want with some of these patients that we're working on with this, especially some of these aesthetic cases, so we got to be able to make sure we can do and accomplish what we told our patient we were going to do. And that's even in the prototypes, so I'm always amazed, and I'm always incredibly humbled and grateful that the trust patients put in their dentist. I mean, that's really an incredible thing. And I never want to violate that. But, someone to entrust in you that you're going to, whatever procedures we're going to do, Kirk, restore the anterior teeth. That's a big deal.
Yep.
And for them to come in and sit and spend maybe a couple hours with us, and if we can have them leave better when they came in, that's great.
Yep.
But there's a lot of steps to go in to make sure that that's going to go well. And if that appointment doesn't go well, that's a tough day between you and your patient. Yeah. So we want you to know that if you follow these protocols, that you're going to have a way to get there predictably, and it's going to be a great day. It's a thrill to have your patient get up a couple hours later and have a mirror and feel better than they did when they walked through your door. I think that's an incredible thing that dentistry can do. Yeah. Now, what other professions get to do something like that?
Absolutely. And that's when it becomes satisfying, is when you're making there are people out there that fix teeth, and there are people out there that change lives, and you just have to decide which business you want to be in. And you've made the decision to be in the life-changing business. Yeah. So take us through your first thought on the protocols on this.
Just quick little recap, if you put up that first slide, treatment planning, we're always going to be treatment planning through what we call the Whittiam rule. Would I do it on me? And essentially what I like about this, something Pete's talked about for years, is that this is ethical dentistry. This isn't about doing dentistry that doesn't need to get done, but it's about really taking the time to evaluate your patients. You've done a thorough examination on them. The patient wants us to solve their problems, so we've gotten the additional records, mounted models, photos. We've gone through a process we talked about in earlier segments on 2-dimensionally and 3-dimensionally working up the case. And that's essentially what it is. You're going to work up that patient, the case, that additional records and information. And that's really how you're going to develop what are the solutions. What do we need to do to solve these problems for our patient, whether they're functional or aesthetic or all of that together. Mm-hmm. So that's a really, really critical first step. You can't do this without that information, because we don't want to guess. The more you guess, the more we're going to be wrong, and you don't want to be wrong on the definitive restoration day. And what I mean by that is the day you put in the final restorations or try them in. We want that to be a predictable day. It's going to go because of all these steps we've done earlier.
Right. And can I just, you and I talk about this all the time, and I just love how you put this in context. Some young dentists watch this and they go, but Drew, my practice is crazy. We always subscribe to, hey, slow down and do it the right way the first time. Would you agree with that?
Absolutely. Absolutely. And that's such an important point, is that you can look at this and you can say, gosh, Drew, this is a lot of steps. I don't have time. I'm too busy. Mm-hmm. You know what? It's going to take you more time and hurt your who you are, and cost you more money if you don't go through these steps, because having to redo something hurts your reputation.
Absolutely. And your sanity.
Well, and then, and trust me, it's just a tough day when you come in and things don't go the way that you want.
Right.
And so if you cut out steps, you're increasing the chances of things not going the way that it should go.
Right. Now, the second thing that you and I always examine is the checklist thinking, because when you vet all of these processes and you get your own checklist down, you don't have to use a lot of brain power and recreate the wheel every single time. You can give your energy to the things that matter most, which is the patient that you're with all the time.
Absolutely. And we've created a checklist for every one of these steps. So, once you have it down, you just follow the process.
Right.
And you're right, following the process that's what breeds the predictability into this whole thing. So you're not reinventing the wheel every time. And I guess in one regard, you can say, there's lots of repetition in dentistry, especially when you start following checklists like that. But to me, kind of the fun thing, though, is even though you're following the same checklist, the answers are different every time. To me, it's like a puzzle. I love going through this 2D and three-dimensional process because we get to answer the questions. And this is something that you're doing not with the patient there. You've gathered the records. The next slide, number 2, those mounted diagnostic casts are so important. So the essential step for this additional records is that we get CR mounted, FaceBow mounted models on our articulator and good models. You got to, quality in, quality out, good impressions, good laboratory work. And then from that, we get to do kind of a trial run on the models. What do we need to do to fix the functional issues? What do we need to do to fix the aesthetic issues? And that's where the plan basically gets developed in that. Now, eventually, we're going to be doing all this stuff digitally, but the foundation and the principles and the steps are all going to be the same.
Right. And in going through this whole process, one of the things that we continuously examine is the digital. People are just so quick to go to the digital, but there's a lot of things that you got to do with your hands first. You can't just give this up to a computer figuring this out because, Drew, I know you figure out a lot. When you're playing with the models, you see the contact points, you can see the wear, you already know what questions you're going to ask the patient.
Absolutely. You're exactly right. You learn a lot doing the models. In fact, if you don't do the models, I think you miss things. I mean, I like having that, seeing it. I think we're still going to be able to do all that digitally, but you got to have a feel for it somewhere in here. Because, the treatment plan changes sometimes from what I think two-dimensionally, three-dimensionally, once I actually get to work it out on the models. Maybe a tooth I thought we needed to restore, we don't need to. Maybe there's one that I left off that now we need to add. Much, much better to add it while you're developing your plan rather than you're halfway into treatment and then you have a conversation with the patient. By the way, there's another tooth or teeth that we need to add, and it's going to change your bottom line and ultimately your fees for this.
Yeah.
So you don't want to have that conversation with the patient the day you're doing all of the dentistry or later on.
Right. Now, I have so many questions because I want to get inside now, and I don't want to get in the way of what you want to say, but you have time scheduled to do this. You're not just doing this at night before you go to bed and all that kind of stuff, because that can be a challenge too.
No, you're exactly right. I mean, this isn't, you're not going through this 2D, 3D treatment planning, I'll refer to it as, during the day. And if you're one of those practices, if you're in a busy practice, you're seeing 20 or 30 patients a day, whatever it is, you're not doing this in the middle of the day. So you got to block some time somewhere. So wherever you want to do it, but, it's got to be kind of that quiet time. It doesn't take a lot of time to do it. A complex case, maybe an hour or something else, could be a little longer when you're first starting. We've with the Dawson Diagnostic Wizard and other things we've added, I can do now in 15 minutes what a couple of years ago I used to do in over an hour. So we've done some things to really kind of streamline the process. But you need some quiet time. You need to schedule it.
Yeah, absolutely.
This is also what drives your practice. If you go through these steps, this isn't a patient comes in, you see them in hygiene, and they've got 1 or 2 fillings, and you put them into your production and your schedule. These needs on these patients are a little bit different. They're probably going to be longer appointments and ultimately more productive appointments. When you have this type of patient, you don't need to be seeing 20 to 30 patients a day. You can't. You've got to be able to take a block of time for this patient that you're going to not have to be rushed, take your time, do what it is that you've decided on. And that's what's going to kind of change your schedule around. I think it's a much easier way to practice.
Yeah, absolutely. And I'll try to connect the dots as best I can, because if you're watching this, you might think, well, am I doing this for every patient? No, like Drew said at the beginning, you're picking specific patients that you're going to invest more time with. You're not giving them less care. You're just investing maybe a little bit more time. Number 2, we talk about this all the time, but you're not working 7 to 7, 5 days a week. You're working 7 to 2, 4 days a week. So you have to be careful about what goes into your schedule and then spending the time figuring out which patient procedures. And number 3 is that overall overall, from a national standpoint, there's no shortage of dentistry to do. There's a lot, and most of it never gets discussed, diagnosed, photographed. You're just giving yourself some space to honor a patient, talk about the truth, and then give them the options.
Yeah, I love what you said, talk about the truth. And, I think it's such an important point, Kirk, because I think some of this, I know early on for me, I had to get over myself. I mean, I had to realize that, this is actually the best way to practice dentistry. And and I think ethically it's the right way. Very, very important. I think this is not about trying to sell dentistry or do things that don't need to get done. This is about really taking time to identify the problems on a patient, having an open and honest discussion about here's what we see, something Pete has talked about forever, signs and implications. Here's what's going to happen. A lot of these problems can be progressive. If we don't deal with them, it's going to snowball. Things can get worse later on. And then if you want us to solve your problems, here's what we need to do. And then let the patient make a decision. So a lot of the patients we take through this process, they've already given us the thumbs up that they want us to solve their problems. If they're not ready for it, you know what? We'll still keep them in our practice. I know years ago I had heard from some consultants that if they're not ready for this type of care, send them to somebody else. That's a ridiculous comment, I think, because a lot of those patients just aren't ready for care yet. And sooner or later, let's do the best we can for them. We can still take care of all the biological things. There's still maybe some reversible means we can do to try to slow down some of the functional things from getting worse. But let's do our best to take care of them. And sooner or later, they kind of convert to that specialty patient, or they're ready to proceed. Yeah. And you don't need a lot of patients to do this. I remember my very first seminar in the 90s with Pete. He said to practice this way, you need 12 to 15 new patients a month. I mean, this is not 30 new patients a week. Because if you had more, you're not going to be able to take care of them. The second thing he said, Kirk, which was incredible, and I lived this, he said, you already have in your practice those 12 to 15 patients that are going to keep you busy for years. And you know what? It's exactly true.
Right. Well, you and I could do a whole show on things that we've heard from Pete that are just so true. And probably in the same sentence, I heard it for the first time. He said, you have a practice within your practice, probably two practices within your practice of dentistry that hasn't been discussed. And I was like, he's so right. And a lot of this flies in the face of what you hear in the world today to get 500 new patients a month. Yeah. And so as a dentist, you just have to watch this. And really what this all comes back to is just core values. There are things that we're going to say on this show that'll resonate, maybe not. And there's nothing better than when you as a dentist decide, hey, this is how I want to practice. And that's what happened for you. Right.
Absolutely. Absolutely. And I do want to say too that there's nothing wrong with having that busy kind of practice. Like if you're a dentist and you like that, back and forth, and you want to see 30 patients a day, and that's how your practice is, that is a perfectly acceptable way to practice dentistry. We're not saying anything badly about that. The dilemma, though, is how you take care of those patients that have different needs that require a different pathway. Right. That's kind of how you have to figure out where you got to take care of those patients.
Absolutely.
So,
yeah. So take us through the next step.
So the next step is the third slide there is basically, this is just the checklist for doing a wax up. So, contrary to how it was in dental school where, just start adding some wax here, there's a method to the madness. And so we just have a 10-step checklist. Like once you get the models, the photos, you've gone through the 2D. I love the two-dimensional checklist. I think it's really kind of the core of this treatment planning part. But then basically, let's take what we worked out in our mind. Let's do it in the wax on the models. And here's an easy way to do a wax up on the models. And that's really what that checklist is.
Yeah.
So, I have that sitting in my lab. So where I probably do about 50% of my wax ups myself. Much, much larger cases I send and I have it waxed up. But even in the ones I send out, I have to do at least half of it myself. So very, very important. This isn't something that you send to your lab and you write a lab script and say, please wax up. There's no direction. There's no information. You're the doctor. Right. You have to answer these questions. If you're going to bring your lab along in this, you have to be able to tell them what they are doing because you're in charge. Not vice versa, because I have this conversation with my lab tech a lot, and he will get scripts. We talked about this last time too, that white paper too from Jeff Stubblefield at DAL, things that people leave out. But it's our job to get the right information, make the decisions, develop the treatment plan. If we're going to wax up, tell the lab what we need to do, not send the lab half the stuff and have them answering these questions for us.
Right. You got to remember, they get hundreds and hundreds of cases every month.
Yeah.
So, and they don't have any space or time to read your mind. And so I like this whole process in thinking over communicate with the technician when it comes to something like this.
Absolutely. And when you've done these checklists, Kirk, it's all I'm really doing is send them the checklist. So so the lab script actually ends up being pretty easy because we just use all this stuff kind of over and over again. I just forward that on because I've already made my decisions there. So they are, kind of what you said, they're kind of inside my mind. I want them in my mind thinking what I'm thinking as we do this.
Yeah, and oftentimes you don't want to be in any dentist's mind at any time.
It can be a scary place. I get that.
It can be. Yeah.
So the next slide, the fourth slide, is kind of putting the 2D and the 3D together. And I think kind of when you get into this, I think this is probably one of the most important slides. So the 2D, if you remember from earlier sessions, we talk about what's off with function, how do we fix it? We start talking about aesthetics and a global, macro, and then micro at the end. But once we've answered those questions, one of the things we want to know, one of our two key starting points to this process is, I'll say functionally, we start with the mounted models in centric relations. So that's why we got to get those models mounted in centric because we think it's functionally stable, and that's how we can have long-term predictability and deal with the forces applied to the dentition. So centric relations is a very, very important starting point for us. The second key answer that we need, especially if we're going to do anterior restorations, is where should the front teeth be? And the starting point for that is the vertical and horizontal position of the maxillary central incisors. And a lot of those steps we go through gives us that in space. So the photo on the left is basically what change we would want to happen based on earlier questions. It kind of puts it together. So in a case like this would be, wanting to lengthen those teeth incisally, and we want to change the gingival proportions. So all of those numbers kind of come together. So in space, we know what we want to do with it. Basically, then the wax up is taking the model and doing what we did in our mind, and let's just apply it in wax on the model.
Right.
We can lengthen it. We can do the gingival work. So we end up then basically with that design in space on where we want the teeth to be.
Yeah, absolutely.
And how many teeth are we going to restore? Here's the other thing is when you do a wax up, however your treatment plan is going to go, and again, this isn't about doing 12 teeth per arch. You might only be doing the centrals. Maybe you're doing 4 anterior teeth. Maybe we're going around the corners and bye to bye or mold or whatever it is. But however you as the doctor determine that you want to sequence this treatment, only wax up that segment because then that segment will be accurate when we go to do the treatment on the patient. So I made this mistake once. I had the world's most beautiful wax up done, and it was the whole upper, lower. It's like, this was great. I'm doing, upper, lower, everything. I wasn't sequencing it that way. So when I actually went to do the work, Glenn said this years ago, Glenn DuPont, I heard Glenn say it, but I didn't listen until I made the mistake. So we do the research for you.
Yeah. So you don't have to.
Yeah. So listen to me on this one. I did the research for you. Because what happens is the wax up then didn't match all of my prep guides and most importantly, my prototype guides. So when I went to make my prototypes, it didn't fit. That's a stressful, it ended up working out fine. It took me an hour longer than I had planned. Things didn't go quite as smoothly as we wanted to go for you. So very, very important when we're doing this, when you're going to sequence treatment, just wax up the sequences that you're going to do, in each appointment.
Yeah, absolutely.
It sounds simple, but.
Well, it's not always simple, but you make the complex simple in this whole thought process.
Yeah. So here's kind of the next, I think, key point of this. So you get to the part that you've gone through the treatment planning. You've done a great examination. Patient wants to solve their problems. We've done the 2-dimensional, 3-dimensional. The patient wants us to proceed. So the big thing on this, Kurt, is why you're doing the 2D and the 3D is actually figuring out the treatment plan.
Mm-hmm.
What is it that we need to do to solve both the functional and the aesthetic issues with this patient? So, and doing that, predictability-wise, we do it again twice. We worked it out in our mind, and then we've kind of proven it on the models, and now that's our kind of our template for moving forward. But the most important thing is, what teeth did we have to treat? What steps did we need to do? Did we need specialists for some of this, and which specialists? So the key here is you got to figure out your treatment plan.
Right.
And how many appointments and how you're going to organize it. And I know for some of these more complex patients, this can get very confusing for doctors.
Yeah, absolutely. Now, you and I were talking about before this is an important step, because one of the biggest challenges, and I want you to speak to this, is a lot of times, even when they do figure it out, they don't write it down, right?
Right.
Okay, tell us why. Why is that? Why? Because you've been there as a dentist.
Yeah.
Okay.
So here's what will happen. I'll say success breeds success.
All right.
And you're going to go through these steps with a patient, and you're going to get there, and you're going to put all this thought and energy into a fabulous treatment plan that's really going to help the patient, and they're going to say yes.
Mm-hmm.
And now,
and then you go, what'd you say?
Now what do you do?
What'd you say? Did you just say yes?
Yeah. And these can be expensive treatment plans, but if you've gone through the processes and the patient wants to solve the problems, you're going to get there. Mm-hmm. The problem then is, well, now what the heck do you do? Once they say yes, because I had it, I was like, I've never had anyone say yes before. What am I supposed to do? Mm-hmm. So you gotta act like you've been there before, and you gotta know how you gotta be able to schedule them. Right. You got to be able to give them the accurate estimate, go over the financial details, get everything on the books. How are you going to deal with it if they need to go through a specialist? So you got to write it out, and you got to write it out in some kind of order. So here's kind of our tips for treatment planning. I really, really think this will help. So the next number slide. So first of all, we're going to call this the checklist for sequencing treatment. So, and sequencing is really important. And I'm going to jump back to one of our early discussions, Kurt, is that it's really important that when you get to treatment planning, that this is not the first time we're talking about fees.
Right.
Because if you're talking about fees for the very first time at what I call it a treatment option review, my success rate for a treatment plan is going to be very, very low.
Right. Now stop there, because I want you you're introducing the idea of a budget or something. Can you give us a little insight on how you do that personally?
Yeah, absolutely. And again, I'm going to say from my trial and error and research I've done for you, I think it's really important to early on, and I will start not talking about fees or talking about budget to a certain degree during the exam. Mm-hmm. I think the most important process, the pillar of this whole thing, is doing a thorough examination so we can identify weak links in the system. Right. But also at the end of it, if a patient has needs, we just have a conversation. And one of the things I ask is there anything that would prevent you from getting the kind of care that you deserve? Mm-hmm. Let me know now, whether it's time or cost, because I'll try to come up with a plan that's going to fit your needs. I think it's that simple. Yeah. And I don't really know my entire treatment planning yet. I get that, but you can kind of get a kind of an estimate. You can tell a patient, gosh, some of these things could be, $10,000 or $20,000. How is that with you? Mm-hmm. And then you're going to get an idea. And maybe a patient will say, I really need it done, but I can only afford X. Mm-hmm. So I'm going to try to then come up with a treatment plan when I get to this treatment option review. That's X for that patient. Right. And there's lots of options we have. And this is, again, where treatment planning, I think, becomes fun to a certain regards, is there's lots of ways that we can stage treatment. Mm-hmm. We have all kinds of interim materials we can use now, from composite to long-term prototypes. I mean, there's all kinds of things that we can do. I think the goal and the puzzle for the doctor is, okay, if this is my budget, how could I budget so much every year, but the end result, we're still shooting for ideal. Right. Some people can do it quickly. I'm in DC, and a lot of people want it done yesterday. So maybe some of those patients, I'll do a lot more sooner for them. Mm-hmm. But I also have patients that they want to get there, but it's not within their budget.
Yeah.
So now maybe it's instead of a 6 months start to finish, maybe it's 3 years, 4 or 5 years. Doesn't matter. But every time we've still come up with the same plan. We go out 4 or 5 years, it's still going to be the same thing. But now what we're doing is we're trying to help the patient get that care with a way that works for them.
Yep.
So we've had that conversation earlier on. So now when I do the treatment planning sequencing, we've already kind of talked to fees a certain degree. I'll be a lot more accurate now, but I'm going to be close to what we talked about before.
Yeah, absolutely. So by the time you present the fee, it shouldn't come with a lot of anxiety on either side.
Absolutely. Absolutely. And, here's the other thing, honestly, is you will get some patients, we talked about this just a couple minutes ago, that they're maybe not ready for treatment yet. Well, we're not going to take them through this process. I'm not going to get the records. I'm not going to do the wax ups. I'm not going to incur that time and cost until they're ready to proceed.
Right.
So it's a little bit like you're stacking the deck. So if you ask me what's my case acceptance for treatment plan, I mean, it's in the 90s or 100%, but basically because I'm not going to treatment plan unless they want me to.
Right.
So
you almost want them asking the right questions, or you can get a sense of this if you authentically pause, listen enough, they're moving this forward instead of you moving this forward.
Absolutely. This kind of dentistry can be hard and it can be stressful. And we're trying to make all that as easy and predictable as we can with you, going through these checklists. But you want to be on the same page with the patient. Again, something I heard in that very first seminar with Pete, these little things, it's amazing how they just keep coming back over and over. But one of the things he said, which I really try to think about, which is super important for treatment planning, is we are the advocate for the patient's dental health. We're doing this together. I'm not forcing you into anything. Honestly, I don't really want to do the dentistry if you don't think it's the right thing to do. That's a hard patient. This is hard enough as it is. So we're in this together. These are your problems. You got to own the problems. They're not my problems, but I can help you come up with the solutions. And if you want to solve them, this is a team effort. Let's do it together. My staff is on board. I got my specialists on board, and I'm there for you. Let's get this done.
Yep. Those are your favorite patients anyway.
Yeah. Those are the best patients. And those are the patients that send you patients that grow this kind of practice.
Outstanding. Now, when we go back to slide number 5 on the sequencing, are there other elements on there? I know you've got your list and your checklist, but other things that are really important to point out as a younger dentist might be thinking about this?
Absolutely. And again, I think this is one of those slides that I would just print and I put it in where you're doing your workups, your treatment planning. So number one is just list all your treatment. So first off, list all the treatment. And this cuts through those things we talked about earlier, meaning your patients are going to have some restorations that have to get done, broken down restorations, decay, whatever it's going to be. What needs to get done? Perio, endo, whatever the solutions are that we needed, list everything. What teeth? What has to happen? And then we're going to designate everything as a stage 1 or 2 or 3. I'll explain that more here in just a second. And then with each of those, prioritize. Where do you got to start? What has to happen first? And then you can get into, as you do this, are there things you can combine to be more efficient in your schedule? If you have a schedule and you have some openings in it, maybe not quite as important, slow down, take your time. But once you start kind of ramping this up and you're doing more in this, there's things we can combine so we can be a lot more efficient. And if specialists are involved, you want to add your note to the specialist. And I refer to my lab as a specialist. That's part of my lab is part of my interdisciplinary team. And so when I write my notes, actually, I'll be honest, I write one, like if I have a referral note and some of these patients might have a couple specialists, endo, perio, ortho, my lab, I write one note to everybody.
That's great.
Because I want everybody to see what each other is doing. So that's my interdisciplinary team. I've spent, a lot of time in the last few years really trying to ramp that up with my specialists. But I want everybody knowing what everybody's doing in order. They get my treatment plan. They get my wax up. They get everything. I mean, not the wax up, but the notes for it. So they get everything. And I want my lab technician to see what I'm doing on my end. The better you communicate, the better this result ends up being in the end. And here's the other thing that once you get this all written up, you got to determine a fee.
Yeah.
And I'm going to say you got to determine a fair fee, and I'll be curious to see how you kind of deal with this. But the point here is it's not this patient needs a couple of veneers or a crown or something else. I charge X for that, so it's 6 times X, whatever it is. This is different dentistry, because if you do it that way, you will end up losing, because there's extra steps.
Yep.
And extra steps could be, maybe this patient, if you're affecting a lot of change in the aesthetics and function, maybe you want them in prototypes for 3 months.
Yep.
So you better charge for prototypes and not give them away.
Yeah. And let me ask you a question, because
Yes.
this is an important piece. You can't look at the rest of the market and compare fees for a lot of reasons.
No.
Number one, you're not doing what they're doing, but there's an X factor here, Drew. It's called time. You're going to be putting time. Can you because everybody makes this mistake. You charge for something and then you spend all this time and you're like, oh my gosh, you couldn't charge enough for this, but you make certain mistakes that you've learned over all these years. But time is really one of the most important pieces of figuring out your fee, right?
You're right. I mean, that's really all we have, right? We only have so many hours a day that we can practice, and that's it. And so you got to get paid for your time. Another one is if you're going to send the case for a wax up, you are going to get a lab fee for your wax up.
Yes.
And they can be $1,000, $1,200. You better add that into your fee schedule, or it's coming out of your profit.
What? What are you talking about? Because wait, dentists don't get big lab bills, do they?
Yeah.
I love it.
Yeah.
Dentists go, I just got a lab bill. I just paid one and I got another one,
So here's something else I learned with these larger, if you're doing multi-unit cases. When I get my lab, when I send it to the lab, we also talk about materials, what materials we'd want to use on this. We make our material selection while we're doing the wax up. But the second thing I want from them is I want the estimate for my lab fee.
Okay.
Because multi-units, again, the lab, just like we do, it's not just 6 crowns and they charge $250 a crown, whatever else it is. There's extra fees that go on.
Right.
So, and again, if you don't factor that in now, it's going to be coming out of your profit. So I want that lab bill because it's going to help me. It's going to help me determine my fees. So I want that early on.
Very
So,
important.
And if I wax it up, there's a fee. Because that means that's an hour or half hour, whatever it is. I don't care what you charge for it. I just want you to be thinking about, you got to determine something, because that means you can't be with patients while you're doing that.
Yeah.
And we don't want you staying to your office till midnight doing all this extra work. There's an efficient way to do this. And it's not about charging and running up your fees or anything else, but you got to factor in these extra steps. And the only way you can do it is to figure out, how many appointments do I need and what am I going to do at these appointments?
Yeah, and I would also say the subtext here, or the alternative plot line that happens in a lot of dentists' minds that they don't consider that they should, is that you have to remember, money invested in dentistry is some of the best money people could ever invest. And if you're telling yourself, wow, this is just going to be expensive for this woman, I don't know that she can afford that. That gets in the way to your ability to truly care for them.
Yeah, I agree. And I think we all do that. I mean, I know I did that, but the problem with that is, and I realized the hard way, is that I was making a decision for the patient,
right,
and I wasn't letting my patient make the decision. It's their decision to make about their health.
Right.
So I can map out things, I can give them the estimates, I can tell what it would take, and then they have to decide whether it's something they want to do or not. But sometimes I know early on, I just never got there because I thought, well, this patient could never do it. When you start having what I'm going to say is just kind of open and honest conversations about somebody's health and long-term well-being, long-term dental health, you will be amazed at the patients that want to seek health. I think the majority of people do.
Yep.
And so we want to take barriers away that we put there to stop our patients from getting what they deserve. Absolutely.
A lot of times there's barriers that we put there, and the patients don't even attempt to put a barrier there. So keep going. This is outstanding.
So the next slide would be then, so once you've written it all down, you've done the 2D, the 3D, these are all the things we need to do, and you've got some kind of idea about the budget. Now we're going to kind of talk about sequencing. So because now again, it's still kind of confusing. So, especially as they get more complicated and we have specialists. So let's break it down a little bit further. So the first stage is what we're going to call biological stability. Let's get the mouth healthy, meaning if there's decay, endo, perio, let's get all that stuff taken care of. And we can do that actually before we go through the additional records that we talked about earlier, the model work, the photos, whatever. If there's bacteriological needs and some of that stuff's getting work, let's get that cleaned up. We're not going to go to the definitive restorations yet. If I have a CEREC machine, I'm not doing crowns that day. But I want to clean things up. Let's get rid of decay. If there's endo, hopeless teeth, let's get all that. Let's get the mouth healthy and sustainably healthy. So number one. So that's kind of where we go from there. And let's get the patient taking care of their dentition. So that's another part of it. So let's get you cleaned up. They're mostly dealing with the bacterial issues there. The second one is now let's go to the functional stability. This is where we maybe get involved in splints with people. We've talked earlier, airway is such a huge thing. We want to make sure our patients can breathe before we start doing this irreversible dentistry. If there's issues there, that's got to get addressed first. So that's part of this whole thing. We want to make sure, again, this is the overall systemic health of our patients. This is just a big thing, I think, as dentistry goes on. But there's a way it fits into all of this. It doesn't stop anything, but we got to address that. Yep. And then maybe this is where the specialists are going to come in. So if we needed ortho, this is where it's going to happen. Perio, maybe we need to put our patient in prototypes, whatever it is. This functional stability is kind of getting them set up for definitive restorations. So if you notice, we're not rushing to definitive restorations. We're setting things up slowly. And some of this might take time. So again, in that second stage, what is it that we need to do there?
Right. Now, just a couple of questions.
Sure.
When fees come up, because I get this question all the time, young dentists are like, well, how do I discuss the orthodontist fee in this? I mean, am I going to start preconditioning the patient? Give us some thought process on that, because I'm sure that comes into your mind, or it has previously in your career.
I'll have, I think once you've done enough, I'll have broad guesstimates of my specialist fees, but I do not want to quote their fees. Right. So I let my specialists quote their fees. Because again, much like as I go through my treatment planning, I might have other nuances that affect the what I need to do, steps, costs, everything else. Same with my specialists. So, but I will tell my patient a broad stroke, to really get this worked out, we need to see a periodontist, want to do some cosmetic surgery on the tissues. It's really going to affect the way this looks. And you know what? That could be a couple $1,000. How does that sound? So I want them to see my specialists well educated.
Right.
And what I mean by that is I've really already told them what my specialist is going to do. And I've showed them as part of our treatment option review. Right. I've given them kind of a broad range of where the fees are going to be. And so when they get to the specialist, they're not hearing that they need this specialist treatment for the first time. They already know it. That's why they're going there. I've been able to take maybe some of the financial part out of it, or at least we waded into it a little bit. But then I'll let the specialist finish things up. And so I think that kind of helps the patient. So it's my fees plus the specialist, and I'm not quoting the specialist.
Thank you for sharing that, because that question comes up all the time. Yep.
Yeah. Now sometimes, they might have the specialist in the office, so that's a different way to go. But, and that's worked out pretty well for me.
Yeah. And a lot of times you're going to send them over there for a consult before we get anywhere near the definitive stages of fees, correct?
Correct. And then circle around again.
Right.
Sometimes I'll do what I refer to as this treatment option review. I might do it twice. Meaning I might present everything I think, and maybe it involves some specialists, and then I'm going to get, is the patient good with that?
Right.
We'll get the consults. I'll get that back from my specialist now, talk to them, whatever I need to do. But maybe I'll circle around with the patient again. You know what? Come in one more time. Let's just run through this to make sure we're both entirely on the same page. And I'll just run through it again. And so it's maybe an extra half hour, 45 minutes of my time to review it. But if you're doing this kind of dentistry, I'd much rather, before we start, before I pick up that handpiece and something's irreversible, I want to make sure that, we're on the same page together.
Yeah, that's outstanding. So take us through the next step. After you've got this all, you've got the three phases, where are we going next?
Now we're gonna do what we want to do. Now we're gonna start to do the dentistry, right? Especially if this is a restorative case. So if it's a restorative case, we start in the anterior, lower anterior first. And here's why. So if we're going to try to set up function, we're starting from centric relation. We deal with the anterior, we can set up anterior guidance. Mm-hmm. Once we have anterior guidance, the posterior is just build the posterior in, get centric stops, and make sure you don't build an interference. And if we can do that, we can satisfy the 5 factors of stable occlusion Pete's been talking for a long time. So the reason we tend to start with the lower anteriors is, just think of it this way. We want stable stops everywhere. Right. You've heard that line we use all the time, dots in back, lines in front. The lines are the guidance. If you have lower teeth that are malposed, they're worn, you have broad incisal edges, you have exposed dentin, they're in the wrong place, it is impossible to get centric stops on the lingual, the maxillary anterior teeth.
Right.
So this is,
now,
yeah, go ahead.
I was going to ask you the question because I've had so many people on here and they call those the hardest teeth in the mouth. Would you agree with that? Or
yeah, they are.
Hands down, right?
They can be. They're small, so however you're going to prep them, whatever you're going to do. Right. So they can be. But again, you know what? With all the alternative materials and everything, there's lots of ways that you can do. And it doesn't necessarily mean that they have to be definitive restorations. Maybe we're going to bond the incisal edges to get those edges and the plane of occlusion and the cuss tips and the incisal plane exactly where we want it. Mm-hmm. And again, I think that's the fun thing with the treatment planning. Do we need to go to definitives or there interim restorations? But you got to get the lower anterior worked out so that we can do the maxillary, because that's going to give us the function. So, and again, hey, this is where sequencing comes in. Maybe your patient is in their budget that we can do the maxillary and mandibular anterior at the same time. Boy, you get that all in the lab, that's great. Maybe they can't, so you got to break it up. That's where the puzzle comes in, and you get to figure out what's the best way to do this. Mm-hmm. But we start with the anteriors, basically. We're always going to look at those lower anterior teeth to see, are they in the right place? Can we satisfy function with lower anterior teeth like that? Once the guidance worked out, then we can do posterior teeth.
Yeah.
Go ahead.
I have one more question because these thoughts come in my head as you're doing this, is that when you talk about putting the puzzle together, it's an important piece as a dentist. You really have to learn how to become a good puzzle maker, good puzzle solver. And that's where you can't stop with your education, because the thinking is what you get exposed to. Because some people say this all the time. I've taken those courses. You got to keep this part of the puzzle making sharp, because you learn so much. You go back and you think, ooh, I see this better now than I did years before.
Absolutely. I remember, so mid-90s, I took all Pete's courses. I did an aesthetic continuum, which was fabulous at LSU. I did some implant. I did Mich Institute implant stuff. But here's what happened to me is the more info I got, the worse I was at treatment planning.
Why?
Well, because I started seeing all of these things, all of these potential problems, functional, aesthetically, implant related, if it's an implant case. And it got so muddled in my mind that the more I learned, the more confused I got. So it's really when I kind of went back to the basics that we're talking about right now that it unraveled everything. Mm-hmm. It's not the complexity of the case. It's taking everything and then unraveling it in these stages. And I think it just opens up. Mm-hmm. I think that the 2D and the 3D and then the treatment planning like this, I'm just going to say every patient, every time. And I think it's going to be successful for you. And I think that's regardless of whether, a patient could be maybe just ortho, and then post-ortho, we're going to do equilibration. That's all we're going to do.
Yeah.
Maybe it's going to be some veneers afterwards. Maybe there's lots of restorations. Maybe it's, an implant retained denture, all on 4 or something else. The setups are all the same.
Yeah.
You've got to figure out in space where things should go functioning aesthetically. And then we figure out what are the steps to get us there. And now let's break it down sequentially.
Yeah. Now let me ask you, be honest. I'm getting a sense that you're at this point in your career enjoying the puzzle more than the actual doing the dentistry itself. Is that true or not true?
I'm going to say 50-50. I love the puzzle, but if I didn't get to actually solve the puzzle and prove that it worked, it wouldn't be as much fun either.
All right. That's fine. I thought it was that.
No, but if you ask me, I love that time when my office leaves and I get to sit down and do the treatment planning. I love it. It's great. Yeah. Yeah, it's fantastic.
Very cool.
So the next slide then, number 7, would kind of be the obvious one, but fill it in. Those three sequences we just talked about. Take your list, fill it in. Also then, how much time would you want for each step? Because here's what's going to happen. Patients are going to say yes.
Mm-hmm.
And then maybe you have to schedule that long time. So be ready for it. How much time do you want to prep, I don't know, 6 anterior teeth? And I'll say, give yourself extra time. And this will kind of come back on you a little bit. You know, on the business side of things, we all have, I'll say, production numbers, you know, so, and we produce X numbers a day to meet your goals, et cetera, et cetera. But this kind of patient, you're going to make or exceed your goal on this one appointment. Mm-hmm. So you could see this patient go home and you've done better than that day that you've jammed in 40 patients.
Right.
It's going to be a more productive day.
Yep.
So once you start doing this, I'm going to say pre-block some of this. I just refer to it as primary care. But maybe hold off. Maybe you work half a day on a Friday. Reserve a Friday for these patients. Don't do it while you're trying to do double hygiene. Don't do it while you've got other patients jammed in at emergencies. Take your time. Spend your time with this patient. You know what? And if you think it's going to take 3 hours when you first do it, give yourself 4 hours.
Absolutely.
Because at the end of it, if you run over a little bit, maybe you have a half-hour break where you can sit and, you know what, be satisfied with a day well done.
Yeah.
You know, take a little pride in that.
Well, and I would always subscribe to what you said, which is overestimate, because if you're a team member watching this right now, you might be working for a dentist who says, oh, that only takes me 2 hours. And you go, are you crazy? Like 2 hours just to get started. And so you don't want to put yourself in a position where you don't have enough time.
Take your time. There's absolutely no reason to rush this on the productive side because it's going to be the most productive thing you're going to do that day.
Right.
Yeah.
Absolutely.
So, and then, you know, again, once you break it down like this, you know, figure your fees. Mm-hmm. And the other thing in here is figure your specialist, because these patients, a lot of them are going to be multidiscipline cases. So get them to your specialist. And I think get them to your specialist and give the specialist the information they need so they can do the best job possible. Mm-hmm. They are, I think, much like the lab. We could probably have a section on what the specialists don't get.
Right.
And so we're flipping it around. You give them everything they need to take out the guesswork. Mm-hmm. That slide we showed a little bit ago when I had the measurements on the anterior teeth, that goes to my periodontist. So he knows exactly where I want to go in 0.5 millimeter increments with my tissue on my anterior teeth. There's absolutely no guesswork.
Right.
What he actually does now when I get my consult back, Kirk, I get 2 photos with his note. One is the one I just discussed, and the other is his post-op.
Okay.
Now, I know he's trying, right? I mean, I know he's looking at it. And I also know that nobody else gives him that info.
Right.
You know, so we want to separate what others do. You want to kind of, you know, stand out amongst the crowd. And, you know, something that, you know, we've kind of talked about at the Academy for a while is we want you to be the go-to dentist in your area.
Right.
And one of the best ways you're going to get there is working with specialists like this. Some of my best referrals are from my specialists because they want good results.
Right.
They know that the extra things we're doing to try to ensure that.
Right. Now, one of the things you're speaking to that I'll just tell you a challenge in interdisciplinary dentistry is oftentimes the GP will refer the patient and the specialist will take over and guide the treatment plan. Now, you know where that comes from. And I'll speak in defense of the specialist. Specialists are like, well, I didn't get a lot of information. So I just thought we were going in this direction. And then it creates the discrepancy that you have between you and your specialist. It's very important to do what Drew you're talking about, which is you have to communicate clearly.
It's exactly the same with the lab, and you're spot on with what you said. And I went through that. And you know what? A lot of the specialists, they're used to doing the treatment plan. Right. But I think they're used to it because the dentist, the referring doctor, the GP, us, the restorative dentist, we don't give them any info.
Right.
So what are they supposed to do? So they take over. It is a totally different conversation, relationship. If you start sending them a 2D workup, a 3D workup, I send them I take 21 photos. They get all the photos. They get my treatment plan and they get my note. My note with, again, as I mentioned earlier, everybody involved in this case gets the note. Right. Now, if there's something that comes up in the treatment plan after they've evaluated the patient, they think, Drew, we can or can't do this. Beautiful. Let's have a conversation and we can alter our treatment plan accordingly because we haven't done anything reversible yet. We're still in the planning stages. I want your input. I want your expertise. I want your opinion. If you think I'm wrong, I'm okay with that conversation too, to a certain degree. But that's a much better way to go. Thanks for laughing at that, by the way.
Oh, absolutely. Absolutely. Yeah. Everybody's got their, their preferences, I'll say.
Yeah. So. But you got to give them the information, and it totally changes the dynamic of your relationship with an interdisciplinary team.
Right.
And it's fun. So we started, I'm going to get off the topic here a little bit, but I think it's important. So several years ago, as I was doing this, I wanted, so who are going to be the go-to guys in my area that I want to work with? Guys or men or women, whoever, the specialists. So who's the best periodontist, endodontist, surgeon, et cetera? And I went to them and I said, hey, listen, we've been working together, or I want to work together. Here's how I do things. What I'd like to do is I'd like to get together and regularly, and we'll meet. So I did this a number of years ago. So probably 6 times a year, I meet with my specialist. It's just the specialist. So we just did it last week. We met in my office. There'll maybe be a topic that I'll go through. But then what we'll do is we'll review cases that are in the pipeline. So, and I let them know ahead of time. So as Mrs. Jones, I give them the lead in. Here's my workup. Where are we with the perio? Where are we with the ortho? It makes us all better. And at the end of this, when we're done and I reshoot the patient, now we review it. How did we do? Did we accomplish what we wanted to? How's the result? What could we have done better? What could I have done differently and given you to make your job easier that would have helped?
Yeah, these technical calibrations are important because they're improving their processes, especially in ortho. You look at what's happening. Everybody's got to know what everybody's up to.
Yeah. And you know what? It's fun too. Yeah, they're a great group of people, and I learn something from them every day. They're up to date, so I'm hearing newer techniques and things that they're doing. It's not a huge time commitment on our part. We throw in dinner and some wine, make it fun. Life is short, right?
Absolutely.
So that's good. Yeah. So that really works. But this treatment sequencing, you got to get to that to get there. And the next slide, number 8, that's just, a quick from my office, but I break it down in the three stages, but again, put what you need there, the sequence, the time, and everything else. So the next part of this process then, Kirk, if you think about it, is now you worked it all out. If you've got specialists involved, you've got everything. You've got your treatment plan. You've worked it out. You've sequenced it. You've figured out your fees. Well, now the next step in this process actually is then to talk to the patient. So remember, you've done, and this really has not been a big time commitment between you and the patient yet. So to get to where we are now, you've done a thorough examination. You've identified the patient as not a general patient, but a specialty patient. You've had some kind of conversation about time and expenses, and the patient wants you to proceed. You've gotten the additional records. So that was a second appointment with the patient, but most of that is staff, not you. Once you do this efficiently, that appointment is just 10 minutes of your time. You've sat down somewhere in your schedule and you've done some 2D and 3D, and that's been a very enjoyable process for you if you figured this out. You've written down your sequence on how you want to do it. You've got it. You've got the answer. So now you got to go back and you talk to the patient. So this is what I call treatment option review. So patient comes in, we sit down. Again, I don't like to do it in the operatory. If you can work this out in your office, I just do it in my private office. We sit down and I have a flat screen monitor and I put photos up. And again, the Dawson Diagnostic Wizard, I think, is so valuable for me because I can show them specific spots where there's issues and here's how we can solve it. A picture is worth 1,000 words. So I really, really like that. This next slide, number 9, is actually out of the Wizard. We have some imaging that we can do. And basically, it's just the outline of whatever we're going to do if it's in the anterior. Here's the teeth we're talking about. And this is kind of the proportions, where we go with the tissue and everything else. And it's amazing. Just those outlines are enough for a patient to get it. And I've done this a number of ways before. I've done what we refer to as that lab presentation wax up. I really don't feel that you need that. We as dentists love that, the pink wax and we can change the teeth and the color and the shading and everything else. I just don't think patients get that as much.
Mm-hmm.
I will frequently do full imaging where take these outlines, we'll fill it in with the two shades, et cetera, et cetera. But lots of times just for the discussion, just these outlines are enough for the patient to get it.
Absolutely. Hey, hold on one second, Drew.
Sure.
I just realized that I pulled my power plug out of my computer, and it's like your computer. All right, here we go. Fired up. All right, we're good. Keep going.
Good. Yeah, I wouldn't want to lose you.
Ah!
So that outline is great when we're having the conversation with the patient.
Mm-hmm.
And then the next step, and I'll go to slide 10. So I will have my treatment plan all written up, my stages, stage 1, 2, and 3. I put it in a folder. The fee is in it. You can talk about how you want to do the fees. Generally, when I talk to the patient about it, I just put one fee. One fee, and however you want to do it. And I actually put plus my lab fee. So I talked to you about I want that lab estimate. I put that as I put my one fee plus the lab. There's the total. That's what the patient sees.
Okay, go back to that because you don't itemize the treatment plan anymore.
No.
I mean, you might itemize the treatment, but you're not itemizing the fee per treatment, right?
Yeah, and again, my research. Now, listen, if there's insurance in here, I'll tell patients we'll break it down, and they can break it down per procedure and what they can put into insurance, et cetera, et cetera. But I used to break down everything, each step. So my prototypes were this. If there's an equilibration, it's this, or whatever else. And maybe it's me being in DC and the president always wants that line item veto, so my patients would want that. So I'd say, oh, this looks good, but I can cut out this step right here. And then I found myself trying to explain that, no, that's a needed step. And so I was doing a lot of time going backwards and covering things like that just doesn't seem to make sense. So I said, all I really need them to know is for this sequence that we talked about, here's the fee. Does that work for you? My staff will break down things and try to maximize insurance for you if you have that. No worries. But what I need to agree on with you is this right? And I've done it that way for years. And I don't get any problems with it. Early on when I first started doing this too, I heard Jimmy Eubanks, who's just one of the most incredible dentists in the country or world. And I felt very good. He did exactly the same thing. I said, well, if I'm doing something Jimmy Eubanks is doing, I'm doing pretty good.
That's awesome.
But that's worked for me. But I do tell patients that we'll try to break this down, maximize your insurance, et cetera, et cetera.
Yeah.
So
now, can I ask you too, because you have a very good thoughtful process. You want your treatment coordinator coming in there, and once you're having the discussion, can you describe kind of the steps that are involved?
So I'll go through again and I'll talk specific about what we're going to do, the teeth, the sequence, and I get patients okay with that. Do you have any questions for me? What specialists are involved? Any questions for me? They say no. I leave, and then Nancy, this is actually a picture of Nancy. Nancy's worked for me since I got out of dental school. I graduated in 1984. And she's got this down. Nancy's got everything. But here's the next step, is that once I leave, I want the patient scheduled. So meaning I don't want to say, here, take the treatment plan home, go home, call me, because it's easy to get lost. They get lost in life. They'll get busy. They're back at work. They're traveling, whatever else is. And now what happened to that treatment plan we did 2 weeks ago? Are they scheduled? And especially if you have specialists, it's easy to get lost. So, and I also want to do as much as we can for the patient to make it easier for them, because they get lost on how to schedule with the specialist. What do I say? Who do I call? So Nancy comes in, and if the first appointment is with my specialist, say the periodontist, she's going to get on the phone right away and call the periodontist, introduce our patient, that she's going to be coming over for a visit. You've already gotten the treatment plan. We need to schedule an appointment, and back and forth, it's scheduled right away. Now, it also might work that if that patient is seeing the periodontist, maybe I know now that 6 weeks or 8 weeks later, I can do my restorative part. So now Nancy's going to schedule that primary care appointment for me 8 weeks out. So I got the patient scheduled. And then Nancy will also go over questions, financial arrangements, however you want to take care of those things in your office. So we got it covered. Also in that little packet I give the patient, if there's specialists involved, I include the specialist cards. So they're all taped right in there. If I've done imaging, I have the imaging printed right there too for the patient so that they can see that, take it home, show a loved one, whatever they want to do. So, but the big thing is I want them scheduled.
Mm-hmm.
You know,
yeah, you can't leave any of this to chance because again, the predictability goes away when you introduce the patient's schedule to the whole thing and they are figuring it out on their own.
Yeah. And, you know, honestly, patients really appreciate it.
Mm-hmm.
You know, it's kind of like concierge service. You know, they're so much happier that you call, you answer the questions, we get the specialist everything they need. So it just makes everything proceed at a nice pace and you're not missing anything.
Absolutely.
Yeah. So, I mean, to me, right there, that's the key with going from the wax up to getting to the treatment plan. I mean, because this is where we want to get, right? I mean, we want to look at our patients. We want to do what's best for them. We want to solve their problems. They say yes. We develop it. We've worked everything out. And now the next thing is what we really want to do. Let's do the dentistry.
Mm-hmm.
Right?
Yeah, absolutely. And you and I are going to talk about that in the next one. There are some steps involved in that. But when you look at this whole process, Drew, give us some, you know, I always like to ask you, what are some of the pitfalls as you look at all of these steps? Because this is brilliant how you have this all laid out. But if I'm a younger dentist watching this, what are some of the pitfalls?
No, and that's great. I mean, we talked about so many things today. So I think the circle around here a little bit are the pitfalls is when we don't follow the process.
Right.
And I know that's the times I've gotten in trouble. I still get in trouble. I mean, I've been doing this for a long time, but if I start cutting corners, I cheat, I don't do the exam, I don't do the workup, it always comes back to get you. There's a reason for predictability. There's a reason for the steps. And it's not to add more time and angst to your schedule. It's to actually make things go a lot more smoothly and predictably. And so if you follow the process, and again, I'm going to say, you know, who do I do it on? I do it on every patient every time. And that improves my predictability. It decreases my stress level. It increases my passion for dentistry and what we do. And to end with another thing Pete said is, you know what? Dentistry is the greatest hobby going. Mm-hmm. And it is if you can follow what I think are these predictable pathways.
Yeah. Amen, brother. Amen. And you and I are going to be together on Thursday at Seminar 1 in Florida for the Dawson Academy. I love it. If you're a young dentist and you haven't been, you have to go. But Drew, if somebody's contemplating going or they haven't even heard of it, what happens at Dawson Seminar 1? So,
you know, Seminar 1 is the overview of the process that we've kind of been talking about in our time together, these sessions together. It's really in your practice, it's identifying these specialty patients and then figuring out, again, these pathways on how to take care of them and filling in the voids, the things we don't know. You know, maybe some of the aesthetic principles, the functional principles, but the big thing is it's how do you deal with these patients that have other needs and the best way to solve their problems. And that's where the predictability comes in.
Yeah, absolutely. And we're going to post a link to the Dawson Academy. Check it out. Come visit us down there while we're down there. And then also, too, I know people are going to have questions about the Diagnostic Wizard. You actually have all this pre-programmed in the software, so you don't have to reinvent the wheel. Tell us about that and how do we find that?
Yeah, so just go to the Dawson website and Dawson Diagnostic Wizard. It's on there. And honestly, the reason we got into the checklist and then the wizard is how can we make this easier for the doctors that go through this to be successful? Mm-hmm. And when I went through, it was, here's the information, you know, go do it. And I mean, I was hard-headed and I beat my head against the wall and honestly made every mistake in the world you could make, but I got there. Mm-hmm. The paper checklist made it easier. Again, all these checklists to help you get there. But is there a better way to do it? Especially now we're dealing with aesthetics and photos and everything else. So we created the Dawson Diagnostic Wizard, and John and I, you know, put it together. But it's basically everything we've talked about in the core, from the preclinical interview to definitive restorations to communicating with your specialist. Everything we've talked about is in one place. Mm-hmm. It just streamlines the whole process. So as I told you, I can do a workup on one of these patients in 15 minutes now that used to take me over an hour to do. And I love the predictability of it. It's everything in one place.
Yeah. Awesome, buddy. I am crazy grateful that you, number one, are my friend. Number two, you share so much great thought and insight to this profession we love called dentistry. And we're going to have you back on so many other topics. But Drew, thank you so much for being on today, buddy. I appreciate it.
Thank you. Always great to hang out with you. And I'll see you later in the week.
Absolutely. And stick around while we say goodbye to everybody else. But we're going to list the links for the Dawson Academy and the Diagnostic Wizard. Check it out and continue to send us some feedback, questions, things you'd love to hear from Drew. And I will just give it to him and we'll create shows around it because, again, this is just a great profession and we're so grateful you're watching. So if you enjoyed today, do us a favor, just hit the share button and share it with your friends. And until we see you next time, keep watching the Best Practices Show. You guys enjoy the rest of your day.